If your patient has hypertension, you need to think about what are the things in their diet and lifestyle that's raising that blood pressure. Well, the lifestyle issues are simple. They're ones we all know. Alcohol consumption increases the excretion and requirement for B vitamins and minerals. Sleep, lack of sleep, increases the cortisol levels, changes the holding on to different amounts of sodium, and guess what? They have increased high blood pressure. Not enough sleep, not enough melatonin affects hypertension. Think about whether they're exercising or not. You can tell by muscle tone that this gentleman exercises. Good muscle tones of upper extremities. We know that if you can just decrease your weight less than 5%, you are going to markedly diminish your systolic hypertension. Let's look at the diet and lifestyle. So the diet, look at the diet and consider, is there adequacy of protein? Are there adequacy amino acids? We know that people who do not have enough protein or too much protein actually have alterations in their blood pressure. Do they have enough essential fatty acids? Inflammation will increase blood pressure through its effect on endothelial function, by its effect on coagulopathy. So you know that you have to consider essential fatty acids in the diet. Are there enough? Are there other sequelae on physical exams suggesting there's inflammation? Consider that. You have to look at their minerals. Do they have enough greens in their diet? If they don't have enough greens in their diet, fresh vegetables, then you have to think about adequacy of magnesium, really the potassium to sodium ratios. You have to think about adequacy of calcium. If they have high blood pressure and they don't eat a lot of vegetables, consider doing the taste test on physical exam, the mouth portion of the exam, because if they're a super bitter taster, they're not going to consume as many greens, which fills right into their issues with hypertension. What you can tell by this, and by looking at the companion guide on hypertension, which is filled with information about the different nutrients and the different medications that affect blood pressure and hypertension, is that looking at a blood pressure determination and doing it correctly will just open a whole array of considerations for you that impact your patient's health. So taking accurate blood pressure is a challenge. It's a challenge in a physician's office. It's a challenge by multiple different levels in healthcare. It's so much of a challenge that, in all honesty, they've changed what they say should be the routine ways to check blood pressure. It used to be that we would rely on a single blood pressure determination and using a wall mount mercury sphygmomanometer. The manual cuffs, also the aneroid cuff, is one we're used to. The challenge with the aneroid cuff is it ages. And the little bellows, the metal plate inside, ages and fatigues. And so the aneroid dial, you want to make sure it doesn't have an automatic stop. If it has an automatic stop, then you don't know if it goes past zero, negative, and so you'll have inaccuracies. These do not have automatic stops, and so it's useful. They should be calibrated at least every 6 months. The aneroid, or the manual cuff, is challenging because, much like we've demonstrated in this series, it requires not only the clinician, whether it's a nurse or a health aide or the physician, to know the proper way that the patient is supposed to be sitting. Feet on the ground, back supported, comfortable, not rushed, and not tachypnic, and in no distress. Don't forget to consider the state of the patient. Are they stressed? Do they look stressed? Are they sweating? Are they breathing fast? Are they having phone calls going off in their pocket all the time? All those things that raise our blood pressure. So when you take a blood pressure in your clinic, you just need to take all those things into consideration before you even place the cuff. Clinically, I've had a number of patients that said it pumps up to 200 and never stops pumping out, and it's too painful. So if you have somebody who has an arrhythmia, you really can't monitor with an automatic blood pressure cuff well. If somebody has fibromyalgia or a regional pain syndrome, just the pressure of a cuff that won't deflate adequately quickly is painful. And that episode can actually linger in the nerve memory for a period of time. So in your fibromyalgia patients, it's better to do a manual cuff than an automatic cuff. Those are the reasons now that I use to help determine when I'm going to use a manual cuff or an oscillating automatic cuff. To put the cuff on, you want to make sure that you have easy access to a shirtless arm. So if somebody is in tight wardrobe, tight shirt, tight sweater, you'll have to put them in a gown. This is ideal. He has a knit shirt that we're able to pull up above, right to his axilla. In placing the cuff, you want to make sure that when you palpate the brachial artery, that the artery indicator is right over, approximately over where the artery is, and then you do the folding of the cuff so that you have good purchase of the Velcro. When you first palpate the brachial artery, which is right there by the head of the biceps, you want to determine when the pulse extinguishes with insufflation of the cuff. That gives you a rough idea of what his blood pressure is. And then you are going to insufflate the cuff 20 points above that line when you begin to listen with your stethoscope and the bell of your stethoscope. Why do you do that? You do that so you can hear the 5 different carot cough sounds. Carot cough sounds are 5 different sounds that have been appreciated when you occlude an artery. You go beyond where you feel the pulse by 20 points, and you begin to let the air out. The first carot cough sound is a gradual increase tapping. The second, tapping followed by a slight murmur. The third is tapping again without much flow. The fourth is muffled, and the fifth is no sound. Those are just 5 descriptive sounds that you will hear when you use the bell of your stethoscope and listen to the blood pressure that you're taking with the patient. Of course, if you're using an oscillating cuff, you're not going to hear any of the carot cough sounds. The carot cough sounds are really not diagnostic. They're more descriptive. So when you're taking a blood pressure and you're blowing the cuff up, what do your eyes see? Well, you've already identified where the brachial artery is, but let your eyes go down the arm. Look at the hair distribution. Look to see if there's any sign of increased solar lenticos. Are there signs of chronic inflammation? Look at the nails. See if there's any inflammation around the cuticles. See if you see the lanula. See if you see any of the lines, any of the markers of leukonychia. So Steve, we have a little ultrasound medium on your foot. And then I'm going to pick up your Doppler pulse. There it is. You hear that? And then we're going to listen to where it goes away. And it should be all right. Well, that's great, Steve. What I can tell roughly from comparing the blood pressure of your lower leg and your arm and their ratio is there's no indication you have peripheral vascular disease at all in your lower extremities. So that's good. So I'm going to check the pulses of your feet and make sure they're the same. I feel them the same on both sides. I'm feeling the pulse in the top of your foot. It's called your dorsalis pedis. And then I'm going to feel the pulses inside, just inside your ankle here. And that's called the posterior tibial. And you know, you have good pulses in your posterior tibial. You know, 15% of the people in your age group don't have those pulses. I'm going to do one other thing. Remember the oxygen saturation meter that we use all the time? I'm going to put it on your second toe. And I'm going to check to see if, once it picks up your pulse, I'm going to check to see if your oxygen saturation changes when I raise your leg. So it's at 97 now, and I'm going to raise your leg about 16 inches and see if it goes down after 15 seconds. And it did not. The reason I do that is it's kind of a very quick test to tell if you have any issues with your blood vessels in your legs. And because you've had some heart disease, and you had a procedure, it's always good to check the vessels that are in arteries farthest from your heart. And there's no indication there's a problem.